Thank you very much for the introduction, and thank you very much for the invitation to lecture this morning. What I'm going to try to do is give an overview of evidence-based imaging and how it applies to pediatric neuroimaging. The nice thing about this talk is that all of the things that we're going to be discussing are not going to change during your career. This is a very mature field. It's based, most of it, on Bayes' theorem that has been around for 250 years, and then on cost analysis that has been around for centuries. It takes a team to do evidence-based imaging, and these are some of the team members that have worked on some of the projects that I'm going to be showing to you as examples of evidence-based imaging. I'm going to be discussing initially the key factors, which is the clinical information, diagnostic performance, and then we'll move into cost and cost effectiveness. And I will use some examples from pediatric neuroimaging to highlight these points. Now, one of the first things that we encounter is, should radiologists read these studies blind from the clinical data? Is that important or not? How do I avoid bias? Is this a fact or a myth? And this was summarized pretty well over more than 100 years ago by Sir William Osler, that said that medicine is a science of uncertainty and an art of probability, and this is still the case and will be the case in the future of medicine and of radiology. So what's Bayes' theorem? Bayes' theorem is fairly easy to understand. It's the information before the test, which is usually supplied by the clinicians, the information from the test that is usually independent from the other variables, and then you put that information together and you get the information after the test. And in more sophisticated terms, you will see in the literature as the pre-test probability, which is the information before the test, the likelihood ratio, which is the information given by the test, and then you put them together as the post-test probability, or the information after the test. The key component here is the likelihood ratio, and again, this is the information from the test, and this is based on the sensitivity and the specificity of your test. So the higher the sensitivity and specificity, the higher the likelihood ratio. And the way I see this is like a coin. You know, the radiologist brings to the diagnostic table a coin, and then when you do any sort of test, and the test that we have shown this morning with functional MR, DTI, advanced imaging, you need to see both sides of the coin. You need to see the head side, which is the sensitivity, which are all of the positive tests on patients with disease. So one side of the coin is trying to see how good the test is for people with disease, and then the tail, which is the other side of the coin, is the specificity, which is basically trying to see how good the test is in being negative in people that don't have the disease. So you need to have both sides of the coin. It's very important, you know, the side of the sensitivity, but also the size of the specificity. And again, these two factors are independent of the clinical data, which is the pre-test probability. So let's see some examples. This is a patient that comes to the emergency department with nonspecific headaches. We do a 3D time-of-flight MR angiogram. Here we can see that there's enlargement of the middle cerebral artery, and then there's an abnormality that we cannot define very well in those branches. So this MR angio without contrast has a sensitivity and specificity of 90%, and you can see that the likelihood ratio is 9, putting both parts of the equation together. So this is the nomogram, which basically summarizes Bayes' theorem. We have these in our department. It's helpful when we have clinical questions, and this is the information that we get from the test. And then we talk to the clinicians, what's the pretest probability? So they say this patient has chronic headaches, nothing else, nothing from a clinical point of view, and you can see the pretest probability is 5, and then with this test, the post-test probability will go from 5 to 30%. So there's an increase, but it's not enough, 30%, to have any sort of important surgical decision making. However, if you have this kind of test and they tell you that the patient has very severe headaches and an abnormal neurologic exam, then your pretest probability is clearly much higher. Your post-test probability goes up to greater than 95%. So the clinical data is very important to increase your post-test probability. The other thing that you can do is increase your likelihood ratio, and you can do that by going to tests that have higher sensitivity and specificity. So we went ahead and we did a CT angio in this patient, and the CT angio has higher sensitivity and specificity of 95%, and here we can define much better the lesion. We see enlargement of the middle cerebral artery, there's a very large aneurysm, and there seems to be a draining vein extending into the transverse sinus. So this looks like an aneurysm. We're not sure if it's a simple aneurysm or if there's a fistula component, but it clearly has much higher sensitivity and specificity than our prior study. And you can see here that the likelihood ratio goes up to 19. And of course, when you apply this, then you're dealing with higher likelihood ratios, and those are going to increase your post-test probability. Now, if we do selective injection, like in this case, then we inject and then we see the enlargement of the middle cerebral artery, this aneurysm, and then there's a fistula draining into the venous side, and then there's nothing else here in the differential diagnosis. Then you have a sensitivity and specificity of 100%, which will be 1, and then your likelihood ratio is infinite. But very few tests are perfect. Very few times we have an infinite likelihood ratio. Most of the time we're dealing with tests in the 80 to 90% sensitivity and specificity, and that's what we have. So we have to either go to tests that have higher sensitivity and specificity, or dig into the clinical data to increase your pretest probability. And that's where we have the clinical guidelines being very important, and obviously your imaging guidelines being very important in order to determine which patients need to be imaged, what are the best imaging pathways to increase your post-test probability, and the information from the clinical data and the imaging data. Now, using some of the examples, one of the areas that is very difficult in order to determine seizure focus and eloquent areas is seizures, and there's a growing number of patients that have intractable seizures that may be candidates for surgery. And then, as Dr. Altman alluded, eloquent mapping is very important. This is an area where a lot of research has been done, and it's a key component. So these are the tests that we have with seizure disorders. We have MRI, which has usually a sensitivity and specificity that goes from 80 to 95%, and I'll show a couple of examples. That's key in seizure disorders because we're trying to determine lesional versus non-lesional on MRI. But then you have other tests that are very important in trying to determine the seizure focus, such as PET, SPECT, MEG, and then you have studies that can be done to determine eloquent areas. You have the WADA test, you have functional MR, and diffusion tensor imaging. So let's go over MRI. So there are different types of lesions that can cause seizures. One of the ones that we encounter often is cortical dysplasia. And cortical dysplasia has a wide range from a pathologic point of view, and also a wide range from a sensitivity and specificity point of view. When you have areas of cortical dysplasia that are very well defined, your sensitivity and specificity is very high, 90 to 98%. But you can have Also, areas of cortical dysplasia with the subtle gray to white matter ill-defined interface where your sensitivity and specificity is not as high. It's 65 to 75%, and you have things to consider: the differential diagnosis, seizure edema, hypomyelination can have similar findings, so you have a higher false positive rate with these cases. And then when we analyze the data in regards to seizure localization with PET and SPECT, you can see that PET, which is usually done during the interictal phase, has sensitivity and specificity usually in the 80s. The best test in regards to seizure localization from these two is the ictal SPECT. When you get a good injection, then your sensitivity and specificity goes into the high 80s and 90s. And the intraictal, you can see here, it's much lower. There are several studies that have not found significant added value from subtraction, but this is what I'm showing you here in regards to the numbers. And then, as Dr. Altman alluded, now there are multiple studies that have shown that functional MR has very high sensitivity and specificity to determine language, motor, and visual cortex activation. And therefore, they have replaced WADA. Why? Because if you have a right-handed patient, the pretest probability is 90% that they're right-handed. If they're right-handed and they have seizures, it's 80%. So if you have the functional MR with such a high pretest probability, a test with a very high likelihood ratio, then your post-test probability is going to be higher than 99%, that's the dominant hemisphere. So you don't need the WADA test in the vast majority of patients. So I'm going to show you a couple of examples. This is the first patient with seizure disorder. This is the cortical dysplasia that this patient has. This one, there's no question, it's fairly easy to identify. We have very high sensitivity and specificity in the very high 90s. There's multiple areas of cortical dysplasia in the right cerebral hemisphere. There's no question, this is a very easy finding to make. There's nothing else in the differential diagnosis. MR performs very well here. And again, this is the same patient. We see areas of cortical dysplasia in the right cerebral hemisphere posteriorly, and also on the left side in a parasagittal area. A different case, case number 2, suspected right frontal seizures, similar clinical history, and then these are the cases that are more problematic. This is the left side, which is normal, nice gray-white matter interface. Right frontal area, there's some blurring of the gray white matter interface. And again, this is areas that could be subtle cortical dysplasia, it could be seizure edema. But again, these are more difficult to find. You're dealing with sensitivity and specificities that are much lower, usually in the mid-70s. So here, the clinical information is going to be very important to correlate with your findings. Windowing is crucial as well to find these subtle areas. So the next question is one study always better than a combination of studies? Can we find the perfect study, the so-called silver bullet? Are multiple studies very confusing? How do we put everything together? The only guy that has silver bullets is the Lone Ranger. We don't have perfect tests. We have tests that we have to put together with the clinical data. So even though we promise that there's this new imaging modality and so forth, it's just a matter of time finding the false positives and the false negatives and trying to identify the true sensitivity and specificity of the test. So we still have to rely on the Bayes theorem and where the probabilities fall. So as I mentioned, you increase your clinical data, and then the other thing that you do is you do one test. So one test may take you from 60 to 80%, and then that 80% from one test becomes the pretest probability for the second test. And then if it's a very good test, that test may take you from 70 to 99% or higher. So that's where you do multiple studies, and you can put them into a Bayes theorem analysis and come up with a much higher post-test probability. So let's go back to this example. You know, people may argue, some people may say it's seizure edema, we're not sure. and so forth. Subtle findings, experience matters. People with experience have higher sensitivity and specificity. So in this case, we went ahead and we did a PET study. You can see that there is hypometabolism. It's worse in the right frontal area. It correlates well with the area where we saw the abnormality on MR. Again, PET sensitivity and specificity in the mid-80s. There's some additional images with, some hypometabolism, but it's not a very striking hypometabolism on PET. So what can we do? We can move to studies that have higher sensitivity and specificity, and in this case, we went ahead and we did an ictospect, sensitivity and specificity in the high 80s to lower 90s, and again, you can see that there's increased uptake in the right frontal area, and once you combine 3 tests in the same area and you lump them together, this is the area of seizure activity in a greater than 95% sensitivity and specificity. So this is very important for the surgeons, very important for prognosis and surgical planning. So you can put all of this information to the neuronavigational system. You can add your sensitivity and specificity of a combination of studies and give a map, a probabilistic map of the area of seizure activity, similar to the probabilistic maps that we see here in Miami often with the hurricanes. I mean, you do multiple tests, and then you come up with multiple tests, and then you give probabilistic ideas of where the hurricane is going to be hitting. So the same you can do with seizure activity. Comes from the same type of mathematical models. And then you can add all the information from functional, DTI, and then give the surgeons a clear idea of where the information overlaps and the post-test probability. Experience matters. It's well known in the literature, not only with MR, but multiple other tests, that people with experience have higher sensitivity and specificity. It applies both to clinicians and radiologists. Clinicians have higher pretest probability. Radiologists with experience have higher sensitivity and specificity. So this is important in regards to getting the most out of the tests. Now, the other question that they ask us often is if you order an MR in someone that has seizures and is being admitted and the test is negative, is that important or not? And then we come to the so-called negative predictive value, and this is very important. If you have a test that has very high sensitivity and specificity and it's negative, you have the negative likelihood ratio. So a negative likelihood ratio, as I will show you in this example, is you do this MR in a patient that has seizures, you don't find a brain tumor, you don't find an area of cortical dysplasia, your post-test probability that this patient has anything significant or surgical is very, very low, less than 1%. So you can discharge the patient very fast. So this is becoming important as we try to decrease length of stay. Sometimes if you do very powerful tests early on in the admission with very high sensitivity and specificity and they're negative, they have a very low likelihood ratio. So if you come with someone that has a probability of 20% of having something significant and has a very low likelihood ratio, it goes from 20 to less than 0.5, 5 in 1,000. Those patients you can discharge and you can do the workup as an outpatient. There's nothing surgical, nothing major going on. So it's a very powerful tool as well when they're negative, when they have a very high sensitivity and specificity. Now, this is in regards to how the test performs. Now, the second step is how do we put everything together in regards to cost and cost effectiveness? And people quite often say, I don't want to order that test because that test is very expensive. I don't want to order the test because the equipment is very expensive. But that's not truly a cost-effective analysis. You need to understand what you're ordering, the cost of the test, and the value that that test has upfront, and then see how that changes the whole workup pattern, and that may, at the end, save money and expenses. So there are multiple studies that have been done in regards to analyzing this. I'm going to be discussing briefly cost-effectiveness analysis. That is the one that is most often used in the literature. But before we do that, I'm just going to discuss a couple of terms. And this is a fairly busy slide, but it summarizes cost data in a very simplistic way. Cost and cost analysis and cost effectiveness is misused. People say this is cost effective, but you need to do a very thorough analysis to see if it's truly cost effective. You need to understand all of the downstream cost and all of the downstream effectiveness. You see the words cost is very different from charges. Cost is what actually you're consuming during a specific procedure. Charges can be any number. I can charge whatever I want. Hospitals charge whatever they want. Charge is meaningless in general terms. So we usually have to focus on cost. And we basically have two components. We have the direct cost, which is usually fixed and variable cost, and then indirect cost is overhead cost, administration, the cost of the building, and so forth. So in regards to direct cost, it's fairly simple. We have fixed cost, which is the cost of the equipment, because you buy the equipment. If you use it 24 hours versus 12 hours, the cost is the same, it's fixed. Variable cost is very important. It changes depending on the use of the equipment. So personnel is always variable cost. The more personnel you have, the more variable cost, and this is very important. It's also important with new tests, as we discussed with diffusion tensor imaging. There's a lot of post-processing. That's expensive. You need personnel to do it, and that's where you need software. You need software to do a lot of that analysis very fast and decrease your variable cost. And then once you put that together, then you need the effectiveness, which is we discussed with sensitivity and specificity, and then you come with cost effectiveness increments, and this is what we're going to be discussing, and then how that affects long-term in regards to life years saved, and then it's not only life years saved, but it's also the quality of life. Someone that has perfect health is very different from someone that has a brain tumor with a poor outcome and has a poor quality of life. So we need to entertain all of those possibilities. This is a very mature data. People that want to learn a little bit more, the U.S. Panel on Cost Effectiveness published the guidelines in 1996. They have not changed. There's also a book that was published and close to that time. It has not changed. It's a very, very mature field, and it's extremely important because we are able to compare different interventions in medicine. We can compare mammography versus MR for brain tumors. We can compare vaccination versus breast cancer screening. We can compare what we do in regards to medical interventions with seat belts, airbags. So you can compare a lot of different interventions. So you will see in the literature quite often that they describe the incremental cost effectiveness, and then what you can use imaging-wise, it depends on the wealth and resources of each country. But regardless of that, all countries have limited resources. The U.S. has limited resources, and we have seen that in the last few years with the Great Recession. But in general terms, most countries consider anything that is less than $100,000 per quality-adjusted life year to be cost-effective. The lower it is, the more cost-effective it is. Now let's do the numbers, and I'm just going to show an example just to take the message home. Children with headache, this is a study that we did in the early 2000s. It's a very interesting topic because a lot of children have headaches, and a lot of clinicians are very concerned that even though they have headaches, that they may have potentially a brain tumor. But if you look at the probability of brain tumors, it's very low. Even though it's the most common solid tumor, second most common tumor after leukemia, the incidence is very low, 1 in 100,000. And the incidence of headaches is very common. Migraines and common headache disorders is very common in childhood. So how do we tackle the problem? So we need to tackle the problem in two ways. One is we need to determine the pretest probability and divide them into different risk factors, and then we have different choices. We can do MR, we can do CT. If CT is positive, do MR, or we can do no imaging and follow them clinically. So we can divide them into three different risk categories: low, intermediate, and high. Low are the ones with chronic headache, normal neurologic exam. So the risk is very low, 1 in 10,000 that they will have a brain tumor. But in the high-risk population, which are children with acute headaches and an abnormal neurologic exam, the risk goes up to 4 in 100. And then we have the sensitivity and specificity of MR versus CT. We also need to entertain what happens if I don't do imaging. What's the prognosis of how is this going to affect prognosis with delayed diagnosis? So we need to enter this into the equation, risk of herniation. And then the tests have risks. There's risks from the contrast agents. There's risk from sedation, even though it's fairly safe, but there are risks. And then the risk of, radiation and so forth. So all of these things need to be entertained when you're studying very large patient populations. But the risk that is the highest is the false positive rate. So when you're scanning a very large group of patients with very low pretest probability, you're going to have a lot of false positives, and potentially some of them may require surgery that may have significant morbidity and mortality or additional imaging and so forth. So you need to enter into the model all of these different tumors with early versus late prognosis and survival into the model, get an idea of every single tumor and their 5-year survival rate. And then you also need to enter into the equation the cost of these studies, and then the cost of favorable versus unfavorable prognosis, and then you come with this cost-effectiveness matrix. So from this cost-effectiveness matrix in the low-risk population, which is 1 out of 10,000, chronic headaches, the best imaging modality is, or the best intervention is no imaging, because the risk is so low that even with MR that has high sensitivity and specificity, you're still going to have a lot of false positive rates, and no imaging is the best technique. However, when you move to the high-risk group, which are the ones with acute headaches and abnormal neurologic exam, then the best test to perform is MR, and it has a cost-effectiveness ratio, which is 67,000, less than 100,000, which is usually the benchmark. So how do we put everything together? Again, physical exam, clinical findings are crucial. You stratify them into high, intermediate, and low risk, select the best imaging modality, and then see what the outcome is. This is a dynamic protocol, so you need to continue reassessment. Some patients that are in the low-risk group, even if you miss a lesion, eventually they will move into a higher risk where you need a different intervention, or they may persist in the low-risk category for a very long period of time. So how do we put this together in the context of what we do in regards to other medical interventions? This was published in the New England Journal of Medicine and is showing multiple interventions in medicine across the board. So if you look at some of the interventions down here, vaccination is cost savings. It has a significant impact in life expectancy. It has changed life expectancy if you compare it with the 1800s, 1900s, and this century. So it has a significant impact. And then when you start moving into some other intervention, beta blockers for myocardial infarction has very competitive cost effectiveness. SPECT and PET followed by MEG, very cost effective in seizure disorders with a normal MR, $10,000 for quality adjusted life years. Here you can see mammography, colorectal screening, also very cost effective. And then we move into other interventions such as the use of hypertensive medication, and then high-risk children with headaches, 50 to 60,000. And then you can see some other interventions that are not very cost-effective, such as left ventricular-assisted devices. The costs go significantly higher for the quality-adjusted life years. So this information is important. You're trying to come up with better imaging techniques at a lower cost that will have a better impact long-term, and this is a way to analyze this. It's not the only way. It's just some parameters that you have to put in the context of the clinical data, but at least you have some quantification of what you're doing and an understanding of the trade-off between cost and effectiveness. So in conclusion, what I have tried to show you is some of the principles of diagnostic performance. These principles have been around for centuries. They won't change, but are very important with all of the new technology that we have, all of the new functional imaging, DTI, and so forth. We need to understand very clearly the sensitivity and specificity of each test. We need to have better clinical data, and we need to have better understanding of the cost data so we can have both sides of the equation and bring better health to our patients.